Hi, everyone. My name is Shubhi Musa. Welcome. Thank you for joining us this afternoon. We are really grateful as Wonka Africa, Afro-PHC, and the WHO in Africa to have a conversation about the Eastern Cape in South Africa. I think lots of focus in South Africa has been on the Western Cape and now Gauteng, and the difficulties of a rural province like the Eastern Cape often gets missed in the conversation. Before I start, I want to just launch a poll just to see if you can tell us while I'm going through some things where you're from. So just tell us where you're from. I'm really grateful for the attendees. If you could just share that with us and just fill in the poll. I'll give you a few seconds to do that. Great. As some of you are actually filling it up, I'm going to just talk a little bit about the panel. They're going to join us, or the platform, sorry, before we go to the panel. If you are using Zoom, you're probably very familiar with it. If you hover over the screen, you should be able to see the settings that pop up on the left upper corner. The first one is your audio settings, and if you're having challenges, just fix that up by clicking on audio settings. You've got the Q&A, please use that function. You can enter your questions at the bottom end and keep them there, and I think we'll find a way to answer that. And please use that for all your questions. You can use the chat option and put some comments out there. Please avoid using the chat option for questions. It makes it a bit hard to deal with it. If you feel you'd like to comment personally, I think put up your hand, use that button to put your hand up. I'm not sure that we'll give you a chance, but if you do, we may just have the option of doing that. If you want to share some of your own experience, if you're from the Eastern Cape, we might find that very valuable. So with that, thank you all very much. I want to just share a few things about what's happening in Africa. I think as you can see in this profile of Africa that you've got a large number of people that are, South Africans that are kind of showing up as the hotspot within South Africa, within Africa. So I think South Africa is quite the challenging space. And so the time we're spending in looking at different parts of South Africa would be very helpful to other African countries. As you can see, the trajectory of growth is growing. We're close on to 1 million cases. In fact, this is of the 31st, but 1 million is a few days away. I think in addition to that, South Africa is a space that, yes, there's a constant growth, and in fact, it has not been quite the same trajectory as in other parts of the world where with our lockdown, we kind of stopped it a little bit and had a kink in it, but it's just proceeded to grow nonetheless. We now have numbers in South Africa that exceed the United Kingdom, which itself exceeds that of other parts of Europe. So you can see that the BRICS is kind of prominent up there. The pattern in South Africa in terms of daily cases is that it's grown, but somehow there's beginning to be a little bit of a tailing off. And you can see from the daily confirmed cases on the right-hand side that it is not quite moving up in this sort of exponential way. And if you look at the daily case trends on the bottom left, you'll see that the Western Cape has been tailing off on the average over the past 3 weeks. So has Gauteng and many other provinces. KZN seems to be growing, and other sort of more peripheral provinces. So clearly Western Cape, Gauteng, and Eastern Cape are not seeing the volumes as they used to see. Of course, that doesn't always translate, these are infection rates. And so the deaths and the hospitalizations, I imagine, are growing. And it is not growing just in terms of the cases of COVID that are reported. There seems to be a very big shift, and I think this is globally, that you have unreported cases and excess deaths in terms of what's reported and what's not reported. The SAMRC has put out data. This is a bit dated by the 7th, but it shows quite a substantial number of deaths that are not in line with the usual annual variation. So this clearly shows there's an impact, whether that is unreported COVID cases or other deaths from services that don't that cause risk to other patients. This is, of course, an unknown question yet. So with that, I want to say thank you very much. We really have a panel that is going to share with us lots of details about what's going on in the Eastern Cape. And I'm very grateful to Professor Yogeswaran, who's basically leading the team from mostly the Walter Sisulu University. She's the head of Department of Family Medicine in Walter Sisulu. And what she's going to bring to us is a panel with Dr. Ben Grant, a clinical manager from Zithulele, Dr. Kaswa, who's a family physician in Mthatha Regional Hospital, Dr. Zingela, Prof Zingela, a psychiatrist at Walter Sisulu, and then Dr. Adene from Cecilia Makiwana, and then Dr. Adeleke from Walter Sisulu. And they're going to talk about rural district hospital issues, epidemiology in Mthatha, psychological issues that they're challenged with, including breaking bad news, and a bit about undergraduate training in the decentralized platform. So there's a widespread of issues that they're going to present. We'll try and break it with some few questions. So as we're going along, feel free. I think we're really pleased that we have more than 40 attendees, and we really appreciate you taking the time off to listen to this team. Dr. Prof Yogeswaran, do you want to perhaps say a few words, and we proceed from there? Thank you very much.
Good afternoon, colleagues. As Shabir said, I'm Yogeswaran from the Walter Sisulu University. I have got 5 of my colleagues here with me today to present different aspects of COVID, which we are facing in different times in our lives, professional as well as our own lives. So what we have done is to put together presentations for about 10 minutes each, and then there will be time to ask questions to the presenters or the panel. We are hoping the presentations will be useful in terms of learning for others from our experiences. Things are still to get hot. So with that, I have got 5 presenters. The first presenter is Dr. Ben Gaunt. He's going to talk about approach to the COVID from the rural district hospital perspective. And he's the clinical manager of the district hospital Zithulele, and he's also a lecturer in the Department of Family Medicine. Let me put out his slides here so that I can hand over to him. Over to you, Ben.
Thank you so much, Prof. And hello, everyone. Thanks for this opportunity. Are the slides? Just waiting to. I can't see the slides. Should I be? Can you see the slides?
Can you see the slides?
There you go. Yes, there they go. Prof, can you just go back to that title slide? Because sure. I think it's a kind of good disclaimer almost. What I'm going to speak about for 10 minutes or so is not the infallible how-to, but really just to try and share some of the things that we found to be useful. And so although its formal title is a rural district hospital approach to COVID, really I think its real title is things we've learned from the mistakes we have made. And I would like to be able to rewind the clock and enhance some of the things we did to try and prepare. But this slide gives you an idea of the context that we're in. We're in the rural Eastern Cape. And so these thoughts really come from there, and I realize people are from a variety of different backgrounds, but hopefully there'll be something useful in this for you. Prof, if we could have the next slide, please. In trying to work out, thank you, in trying to work out what the best way of spending 10 minutes with you, I decided that actually structuring it as first aid for COVID was a nice primary healthcare approach. So we're going to do help, hazards, hello, and then A, B, C, D, E, F. I'm not sure if it really goes to F, but let's work through those things. That's basically what I'm going to be saying this afternoon. If we could go to the next slide, please. So help, I mean, this is, if you're arriving at the scene of a disaster, help is obviously the first thing you do, call for help. And usually it's a nice, easy emergency number. But I think in COVID, identifying who the key role players are might not be quite as easy as dialing your national emergency number. So working out who they are, those might be influencers. I don't mean people with lots of Instagram followers, but the people who tend to drive the conversations within a facility. Who else is willing to help? Because obviously there's leaders who should be involved by virtue of their job description or their position, but they're people who are willing to put their hand up to be part of a response effort. And so pulling them in and engaging with them meaningfully is really important. And I've said start talking early. I mean, help is first up, but it's never too early to start having conversations. The reality is that it's a challenge to get your head around this epidemic, and depending on how far down the road you are in your particular facility, you will know exactly what I mean. And then I've put there unions and junior staff are important. I think, to be honest, we haven't been a big union kind of driven hospital in the past, but the amount of kind of panic really changed that when it came to COVID, and the politicization of this epidemic was quite noticeable. So if you if you're able to include union representatives and junior nurses, anyone who's really afraid and willing to talk, get them on board. Next slide, please. I'm speaking, I should say, from the perspective of a district hospital. It's usually a smaller institution, so obviously this doesn't apply to the massive hospitals, but a lot of it will as well. And then hazards. I think if there's one thing that I didn't completely get, partly because we actually had good stock of PPE, but the reality is that in my worldview, I think kind of healthcare workers, our core value number one is prioritizing patient care, really putting the patient first. But with the level of fear, and particularly what was driven by the media in the early days of people dying, and the mortality rates and risks involved, just meant that for a large number of staff, they weren't able to see their patient until they felt safe themselves. And obviously, that we want to be protecting staff, that's to everybody's advantage, but actually almost completely forgetting about the patient to start with, not the physical patient in front of you, but the theoretical patient. Don't underestimate how terrified people are. And remember that physiologically, that means they're not going to think straight. We found it important to try and get a committee together. That's quite a process sometimes as well, but to represent every section. In your mind, if you're a clinician, you might think that the clerk stuck away in an office capturing data is low risk because they are from an institutional point of view, but they will still probably feel like they want to dress up like it's the movies. And it's really important that you engage that fear and help everyone feel like their protection is a priority. And I've said they don't save for a rainy day. I think that, in wanting to make sure our PPE would last, we ran the risk of trying to be too conservative. We actually, we were more generous than the guidelines, but it still was a challenge. And so I think I can't emphasize the PPE part enough. Whether you've got good supply or poor supply, getting everyone on board, getting the guidelines kind of well distributed and signed off is super, super important. The next slide, please, Prof. And then kind of hello, I was trying to fit that one in, but really starting to plan. You know, how much do we know? How much is there? Our patient. Don't assume that anyone knows anything, because there's an extraordinary amount of misinformation out there, and even people who have dealt with infectious diseases for years don't know what to think about this new disease. So really challenging terrain, but really important to involve, again, like I said, all age groups and sections. I think we found sometimes that having just kind of managers who tend to be a bit older and sometimes a little bit more hierarchical or set in their ways meant that junior staff didn't feel like they had a voice, and that can cause trouble, especially in a small institution, but perhaps anyway. Next slide, please, Prof. So my attempt at ABCD, 8, triage. We really found this to be important, and I think it is important regardless of the size of the institution. It helps create a bit of a focus on what's happening. The ability to identify and sort at source is really important. We found trying to make a team of people who were involved, nurses who felt responsible for it. We involved clinicians that actually didn't always feel like the best use of our time, but it was absolutely worth it in terms of getting buy-in and helping people to see that it's important. And likewise with managers, I think if it's something that people get told to go and to sit over there and do, it's a little bit boring, to tell you the truth. I've done it myself, but it's critically important, because otherwise you're just going to be overrun with COVID and everyone will panic and run for the hills. Let's go to B. Please, the next slide. So be proactive with your nursing plan. You wouldn't want to send in nurses looking like that. That was a World War II photo. I tried to find a nice inappropriate nursing photo, but really the allocations of nurses to avoid discrimination and stigma amongst the nursing staff, and also just the planning of the physical spaces, the wards. Are you going to put them in this space or that space? Do you have enough capacity to give people oxygen if it's in that particular room? Can you isolate your PUIs from your other patients, etc.? And then really a conversation or a dialogue that we didn't really drive enough was that COVID is everyone's problem. I think a lot of people felt that, you know, if we can wall it off, and of course that's the mindset with gate triage, that you're trying to identify, sort, and then isolate, but then suddenly it becomes somebody else's problem, and it's probably healthier to seek ways to make it everyone's problem from the get-go. Next slide, please, Prof. Clinical care is obviously important, so I'm making that C, and I don't want to rehash guidelines that are available elsewhere, but and where others are more equipped and expert in than I am. But I think that's often my mantra when it comes to clinical care is focus on the basics and get that right. If you do the basics right, especially at district hospital level, you get most of the benefit. And so having clear admission criteria, knowing what they are, making sure your team knows what they are, ensuring that you've got oxygen availability, giving steroids to people who need oxygen, that's evidence-based, and making sure that you know who's going to get your IV steroids and who's going to go with orals, because you're not going to have enough stock of IVs. Clexane, if you've got access to it. Positioning, simple but quite different to what many of our staff are used to, prone positioning for the patients who are hypoxic especially. And then not forgetting the differential. We found that to be an important thing to emphasize clinically. There's still a lot of TB out there. There's still people getting community-acquired pneumonias, and people with impaired immune systems still get PCP. So we forget those at our peril, and they're important. The basics are important in a district hospital setting. Next slide, please, Prof. Can we move to D? There we go. If you're a scholar, thank you. If you're a scholar of Greek mythology, you'll recognize that as Atlas. with the world on his shoulders. And D is just really simple. Don't feel like it's all your responsibility. If you're a Enneagram type 1 or a person who feels responsible for your organization, or if you're in a position of responsibility, or even if you're not, you might feel like you have to do your bit to save people from COVID. And of course, we all have a role to play, but I think realizing that we're in it together and that there's only so much that we can do is actually really important for our psychological health. So I've included that as D. Prof, if we can get the next slide, please. You can see my first aid mnemonic is starting to fall apart here. E is everything else. And I don't want to spend a long time on these because although they're important, each one of them could probably be a talk, but making sure you've addressed things like visiting our policies and food and who's serving it, and is it on disposable plates, or who's washing the plates. All of those things are actually important both for infection control and also for staff psychology. Simple things like phoning results, contact tracing, they're quite hard to do actually, especially if you're working in a setting with limited capacity. Screening staff, again, there are government guidelines in South Africa for that, but it's not just about taking a temperature. It's about helping people understand the role of symptoms in understanding whether or not you need to be quarantining or testing. And then I've also included their good statistics. There's a tendency sometimes, especially in places where we feel overwhelmed by the clinical workload, to get stuck into the work. And then this is a very political disease. And if we don't know what's actually going on and can't put numbers to it, it's easy to lose people's confidence. So I've included that one in there as well. Prof, if we can go to F, which is my last or second last slide. Have fun. I think, again, looking back, we all took this very seriously, and it is a very serious disease, but it's also there are moments when you can just take a deep breath and remember that the rest of life continues as well. So I included my son, who loves Lego, made these little vehicles, and I just thought that's an example of having fun. It's a serious thing. He wanted to say thank you, and we sent it around to a few people, but it's also, there's some beauty in life despite the challenges, and the sea in the background if you're lucky enough to live near the coast, although you're still not meant to go to the beach. Prof, I think that's the last slide, is it? There's a rainbow. The rainbow is really helpful to me just to remember that the storm will pass. And yeah, I hope that these thoughts, brief though they were, are helpful in some way and will help you wherever you are to prepare yourself for the storm, but also that it can be an opportunity for your organization and hospital or clinic or wherever you are to actually grow and be strengthened. I think we took quite a beating in some ways, but I remain hopeful that we will grow from this experience together, and I hope the same is true for you too. Thanks so much.
Sounds great, Bren. I think Yogi, you want
yes,
to...
I think let me introduce us. Thank you, Ben. Let's have the second presentation, and maybe you'll have questions after that. The next presentation is on epidemiology and comorbidity in COVID-19 at Mthatha. It's going to be presented by Dr. Ramprahash Kaswa. He's a family physician and the acting CEO at Mthatha Regional Hospital at present. And he's also a senior lecturer in the Department of Family Medicine and Rural Health at Walter Sisulu University. Over to Dr. Kaswa.
Thank you, Prof, for the nice introduction, and good afternoon, everybody. As Prof mentioned, that I'm Dr. Kaswa. I'm a senior lecturer in Department of Family Medicine and the Rural Health. I think, yeah, that's my slides. And I'm currently working as an acting CEO in Mthatha Regional Hospital. So what is my presentation is mainly, I think Ben is already presented about the overview of the Eastern Cape. Now my presentation is mainly meant for the number. So I'm going to play here and there some numbers. Prof, maybe can next slide. Yeah, so my overview of my presentation is going to be the little bit introduction, and then I'm going to go for the statistics for the testing and the screening. And then I'll go from there some recovery, how many people we discharge, statistics, their comorbidity, and then I'll go around the patient who died during the treatment phase of COVID-19 and them also related morbidity associated with them. And I'll end with the summarizing the lesson learned during this pandemics. Next slide, Prof. So we all know that the COVID-19 is caused by the new strain of the coronavirus, and that was emerged from the Hubei province in the China is the late 2019. So coronavirus is mainly classified as the big family of the coronavirus family that mainly causes the common cold or flu-like disease in the human, but the new strain is more severe disease that causes sometimes acute respiratory distress syndrome, and sometimes it ends up with the death. So the COVID-19 usually present with the common symptom like cough, shortness of breath, sore throat, and loss of smell, taste, or the fever. What we got the patient, because we are in the regional level package services, so most of the patient we receive either maybe the bedridden, so hardly any patient we get any who complain with the loss of smell, because most of them they are come very sick patient. So main presenting complaint is the alignment either shortness of the breath or cough. Prof, maybe move next slide, please. So in initial symptom, when we saying the mild symptom, usually they will present with the dry cough, fever, and the tiredness. And when the disease get more severity side, then it develop maybe the high kind grade of the fever, this multi-organ failure, and is ended with the death. Next slide, Prof. Yeah. So if we go through the epidemiology of the new coronavirus, I think majority of the patient will get the mild grade or the moderate grade, and that compensate around the 80% of our infection. And majority of them, they recover without any residual complication. So 15 to 20% who develop the severe to the critical disease, out of them maybe few percentage will be end up with the severe course of the disease, and then this category will be end up with the death. Next slide, Prof. Now, I would like to highlight where we are belong to. So the Mthatha Regional Hospital is in the Mthatha, is the KS sub-district in the KSD, belong to the OR Thambo district. We are on the eastern edge of the sea coast. So that's the map indicating where we belong to. Next slide, Prof. Now, we started our testing, I think, the second last week of the March, when we have the first case. And the important thing regarding the first case, when we reported, I think it was after that we reported that the patient was tested positive. And our journey started from the last week of the March. So the state what I'm presenting it from the last week of the March until the second week of the July. These are the data. We tested around 2,000. The test available until the second week is around 1,849. Out of them, there's 392 is tested positive that we are standing currently. The positivity rate around overall 21.2%. Total death in the facility, we reported around 114, and total number of the discharge from our COVID ward, we have until the second week is around 130. Total number of the staff tested up to now is 130, and the majority of them, I think we recovered back. So 87% out of 130, the staff out of 130 is returned back to the work. And unfortunate part, we lost one staff member during this COVID battle. Next slide, Prof. These are the breakdown of our tested patient. So you can see the majority of the male, 65%, like 2/3 of the patient is from the female, and the 1/3 is around the male. Not stated around the 6% is not indicated. So these are the distribution of our patient. Next slide, Prof. So this graph is indicating the age distribution of the age for both male and female. If you can see both the male and the female, there is no difference between the age distribution. Only the difference is the female is out in number, more in number than the male side. But the mean age of the both male and female is there is no difference. Next slide, Prof. Now this slide is mainly highlighting the mean age of we tested. So the first row is showing the positive patient whom we tested. The mean age is 45.5, and the negative patient is 41.6, indicating, highlighting that the people who tested positive are in the higher age category compared to the who tested negative. Next slide, Prof. This slide indicating our monthly distribution of the number of the patient flow. As I previously mentioned, our journey starts from the last week of the March, and we tested, I think, 2 patients during that time. Then in April, we starting the pickup from the testing increasing number. So up to April, I think we have the facility from the NHLS when we testing is not locally testing. They're sending all the sample either Pretoria or Durban. After May, I think they started local testing, and then the number is starting increasing since then. Now the second column, you can see the mean age. That is interesting interpretation is there. From the April to July, the mean age of the testing patient is increased, indicating that when we start the epidemics, the young people is flock inside the facility for testing. And when the epidemics is getting mature, more elderly people start coming in the facility forward for the testing. So that is highlighting in these numbers. Next slide, Prof. This one is the monthly distribution according to their gender. As I previously mentioned, the female is more in number, but the pattern is almost same. Recent week, we just, the data is in July is less because it's covered until the second week of the July. But from this week, the number of the patient influx in the facility, we saw dramatically decrease, both for the testing and the positive testing rate also. Next slide, please, Prof. This one is showing the positive and the negative rate. Initially, when we start the testing, everybody, when the first case was tested in the end of the March, all the community fearful, and everybody run to the facility for the testing. So the positivity rate was very low during that time. And in is end of the May, when the NHLS is give the feedback that they have the high number of backlog, then we change our strategy to who is qualified for testing and who is not qualified, supposed to be qualified. So we change our strategy, we more selective for testing, then our testing rate, the positivity rate is increased. You can see according to the month we pass in the epidemics. Next slide, Prof. Now, this slide is clearly highlighted what I mentioned in the previous slide, our positivity rate. So if you can see in the last column, that is showing the positivity rate. In the April, we are sitting around 2.6% positivity rate, and that will be increased in the July around 35.8% positivity rate. That means in July, every third patient we testing, one is turning positive from them. That overall testing is around 21%. So that is again demonstrating our selectivity of how we testing. Now, this is the age category distribution of the positivity rate. The lighter column is showing the positive and the darker column showing the negative. The elder, when we go increase with the age, the positivity rate is increasing. That is demonstrating in this graph. Next slide, Prof. Now, this slide again interesting is showing the mean age. So I compare the mean age between the all tested positive and the patient whom we discharged and the patient who died in the COVID ward. So total number of the patient we tested positive is 384 with the mean age 45.5. The patient who recovered is 130 with the mean age is 49.58. And the people who died around 112, mean age is 61.39 year. So it's clearly showing, demonstrating the data that the people, elderly people at the higher risk of death. The slightly increased the COVID recovery, because remember all we tested the people, young people who tested and they're asymptomatic, we down refer without admitting them and they are lower risk category. So that's why the mean age of the overall COVID positive is 45, but the mean age of the recovery patient is 49, slightly higher. But clearly there is a marginal difference between people who died. The mean age is more on the higher side, indicating higher risk with the age category. Next slide, Prof. This one again is showing the patient we discharged from our COVID ward, the male and female according to their age category. So the female in the younger age, higher number, but when we go on the higher age category, the male is outperforming, except there's a one category from 41 to the 50. Next slide, Prof. This one is showing the comorbidity, the patient whom we discharge. So the diabetes, and the first column is showing the diabetes from both male and the female. More male discharge with the diabetes compared to the female. And when the comorbidity increase, I think diabetes, hypertension, and diabetes, hypertension, then hypertension, low respiratory tract infection, others, and the highest category whom we saying we can discharge if they have no comorbidity. Next slide, please, Prof. This one is the patient who died according to their age category, the gender distribution, male and the female, like hardly any difference with the pattern between the both gender, but people who have the higher age category is more risk of the death. That is demonstrated with the graphs. Then this one showing the comorbidity of the people who died in the COVID ward. So the diabetes and diabetes plus hypertension, that is the two main category people died due to the COVID-19. Initially, we thought maybe that we have the higher number of the population who's HIV positive in the community, surrounding community, but we noticed very low number of mortality in HIV positive patient. That is demonstrated in the graph also. Now, this one is an important slide for me because I compare the both comorbidity, the people who discharged and the people who died in the COVID ward. If you can see in the bottom column, the diabetes alone is the death and the discharge. So in the death category, diabetes alone is higher, slightly higher than the discharge patient. But if you see the third column, when we add the diabetes plus hypertension, the proportion is almost double who died. And if I add the third category, diabetes plus hypertension plus HIV, the RVD, then all people are died. No one will survive with the all three comorbidity. That is showing the dark blue graph. And if you can see the people who just have the comorbidity of lower respiratory tract infection or community acquired pneumonia, all of them they discharge without any mortality rate. Next slide, Prof. Now, this is the, I think the review published on the 2 week before on the Lancet Journal regarding the highlighted the importance of the diabetes in the COVID era. Why the diabetes is so important in the COVID era? Because the mortality rate associated with the diabetes is the highest we notice in our statistics. And that is in same alignment what this review is highlighted. Next slide, Prof. Now, this is, I summarize what the lesson we learned from this epidemics. So the first lesson we learned, the diabetes is the most common comorbidity in our patient, either who we admitted and who died in the COVID ward. And diabetes alone, it is associated with the poor outcome. Then the next isolated factor we notice is the age category. The mean age higher, people are the higher risk of the death. But age alone is not the risk factor. We saw from our ward, COVID ward, the people from the 91-year-old data just walk away, and 19-year young man or who have the comorbidity just scrumped or died in the COVID ward. So that's why I would like to highlight here the diabetes management is the optimum management, can save the life of the COVID. I think that's my last slide. Thank you very much for listening to me, guys.
No, thank you very much, perhaps, and really appreciate that. I think the message is clear from what you've said. I think the question of, elderly diabetic hypertensives are clearly the risk group. When I look at that and see, also from Grant's, from Tom's, from the participants, we basically are looking at, from Ben's presentation as well, that we're really living in an uncertain space. Perhaps, Ben, you can respond to this question quickly. How do you manage with terrified staff? Mukund Bahadur Katuchetu is asking you this question. What do you think? How do you manage these staff members that are so terrified?
We didn't get it right, to tell you the honest truth, certainly not to start with. I think the first and most important thing is don't try and reason with them. Because fear drives out reason. And it's unfortunately, it comes across, unless you are a better reasoner than I am, as all I can hear is you're not taking me seriously, or you're not taking my fear seriously. So I think that dealing with terrified staff is about sitting down with them and trying to hear what their fears are, and that might take ages. And finding a way together, kind of asking people, okay, we get kind of what the fears are, but how do you, how can we manage those things? How can we protect you? What will help you feel better? I don't think I had the patience to do that properly, and it is difficult at the scale that we're talking about, because we're talking about every single staff member, for better or worse. And so perhaps it's about also breaking or dealing up the kind of the hospital or facility into sections, and having different people engage different people, because one person can't do it. So yeah, I think it is, unfortunately, I say unfortunately from a time perspective, about a lot of talking, but it's not about reason, and it's not about guidelines. I learned that the hard way.
Yeah. So Ramprahash, there's a question that you might be able to respond to, and Ben, you might be able to also respond to it. I think Marion asked the question. I think, Ramprahash, you sitting as CEO, besides being family physician in Mthatha regional, so you must be having, as you've described, quite sick patients coming in. She asked the question about how do you manage your oxygen sats, and how do you risk manage your patients coming in? Would you say, I mean, I prefer giving someone who's not very low the oxygen, or I give the person that's sicker the oxygen? How do you manage yourself in terms of your oxygen supplies? And maybe you can intimate a little bit of your challenges in managing patient burden and what you've got in terms of resource.
I'll have a quick.
Thanks, Prof.
Yeah, let Ramprahash, and then we'll.
Yeah.
And what we'll do, we'll come back to this. I know there are a number of other questions, but we may run short of time. So a very short answer, and then we'll move on to the other three. And then when we get back, I think we can bring up some of these responses again. Great. Ramprahash, perhaps you can just quickly respond to that.
Thanks, Prof. I think where I'm sitting now in the position is really hard, because between the rock and you can say. But what we learned during we don't have the oxygen tank supply. So still we are dependent on the AFROX supply. And what I present the data, the mortality data, I think there was one night when we just run out of the oxygen, and we lost around 10 patients that night, middle of the night. And what our consumption of the oxygen, like 4 times higher than the normal consumption. So we use, I think, oxygen cylinder, how much we using a weekend, 100 oxygen cylinder we are using just for a weekend only. Yeah, it's quite amazing. Regarding, we are in the referral hospital, so most of our patients, what we receiving are either oxygen dependent. But the mortality rate is high, because if I can break down of all the data, 1/4 of the patient are almost died before the arrival in my emergency, or they died in next 1 to 2 hours. So that kind of the mortality I'm sitting down. So definitely no, we have a lot of complaint regarding the patient also. Maybe you hear in some of the newspaper that the patient is fighting for the oxygen. So it came one time when the AFROX, who is the supplier for the oxygen, who was affected by their own employee, and they closed down. And in that, I think the few days we really struggled for that oxygen.
So in that time when you struggled, how did you manage the sort of the ethics of, or the clinical stroke ethics management? Very quickly, if you did, otherwise, if you had plenty of oxygen and didn't need that difficult decision, then it's fine.
Yeah, Prof, it's really difficult, especially for the staff who is taking care of the patient. They were very traumatized. So the next morning when we go there, everybody was so down that they can't take that stress if someone is dying in front of you and you can't do anything. That was the most traumatic experience we feel. So everybody who was taking care of that night will be go under counseling before they come back again to the work. That was really traumatic experience.
Well, clearly you better capacitated, it seems, in some of the other settings, maybe people are relating. So I'm going to suggest that if any of the speakers, any of the panelists can type some answers to respond to some of these very specific questions, feel free to do that. I'm going to say, let's move on. Yogi, if you can just present the next person, and then we can carry on. Yogi, who's next? Has Yogi left us? I hope not. I think... Yogi, are you able to hear us?
Can you hear me?
Yes, now we can hear you. If you can just share the screen and introduce the next person, I think it's... where did my thing go?
Okay.
I think it's Prof Zingela that you are introducing. Yes. Is he on the call? He doesn't look like he's on the call, is it? So maybe you want to move on.
Prof Zingela, are you available?
I don't think he's on our list, so I suspect you've only got 5 people. So I think he's not quite on the list, or 4 people. We've got yourself, Ben, Kay, Ramprahash, and Vincent. He's not on the call unless he's, oh, hang on. He's actually joined us in another way. I think there he is. He's able to speak now. Prof, let me just quickly advance you to this. You are able to join the panel, and I think
I have just lost my screen.
Yep, he's joined us now. So that's fine. Prof Zingela,
Okay.
you are able to speak now. If you just unmute yourself.
Thank you.
There we go. All right.
I have unmuted myself, and I actually would, yeah, there we go.
Yeah, there we go.
All right.
Thank you.
No, I think the problem was that I was muted, unfortunately, and I didn't have the ability to unmute myself until you had done it. Okay, thank you very much. I am Zukiswa Zingela. I'm the head of Psychiatry and Human Behavioral Sciences at Sisulu University. I'm also based at Nelson Mandela Academic Hospital, which is right next to Mthatha Regional Hospital. I'm going to be taking us through the mental health aspects of a pandemic. And I'm going to ask Prof Yogi, if you do not mind, fast forwarding to slide number 8. And that basically is looking at the mental health aspects of the pandemic. Yes, this one. Thank you very much. So I know that there was already a question asking about how one handles the fear and anxiety, especially among staff members. So just to highlight that if we look at any pandemic, especially if it's associated with a number of people who are sick and who are also dying, especially if it happens acutely, then it is quite normal to have anxiety and fear or panic around the pandemic, whether this is now in the general population or it's amongst health staff. And this is seen as a natural reaction or natural state to a highly abnormal experience. And there's also, of course, an increased risk of developing mental disorders, and there's quite a range of them. You know, it could be adjustment disorders, acute stress disorder, post-traumatic stress disorder, and so on. Next slide, please. And when one is faced with a pandemic, it's obvious that one would then be looking at the mental health needs of the general population. But in addition, it is important to keep in mind vulnerable groups. This includes, you know, the elderly, it includes the disabled, it includes young children, or even victims of gender-based violence. Next slide, please. So one then has to look at what would be the role of mental health teams during a pandemic. And one of the things that we have been very cognizant of in South Africa is that, especially in the Eastern Cape specifically, it is just not possible to address the mental health burden or mental distress that is experienced because of a pandemic through targeting it via mental health teams alone. It becomes important to try and form partnerships with different organizations within the communities, with different government sectors, which can also assist in supporting not just the community, but the general healthcare workers as well. Next slide. So what is therefore important is that one has to also accept that it's not everybody who's going to be experiencing mental distress, but it's a significant portion of the community still. So it does help to provide information on how to access help to meet basic mental health needs to anybody who might need them. It also is important to facilitate easy access to a process of assessment and intervention should somebody be suffering from mental distress. It is, however, challenging, as I mentioned before, to do this within a resource-limited setting. Next slide, please. And in such instances, it is important for the mental health teams to identify and communicate the criteria by which they will then accept referrals specifically for mental health distress, which is precipitated by the epidemic. Next slide. This is just a slide that talks about frontline healthcare workers and results that have come from different sectors, including the one from China, which was the epicenter in the beginning, where they found up to 50% of the people surveyed in more than 2,000 healthcare workers came back reflecting some kind of mental disorder, which included an increase in substance-related disorders. Next slide. So that was just the preamble to give us an idea of what one would expect in terms of mental distress or mental disorders when faced with a pandemic. So if you then look at the psychosocial support that should be offered, I've mentioned before that it's not going to be possible, it would not be possible to address it just as mental health services. So lessons learned, it has to be multi-sectorial. Also has to be multi-pronged, meaning it cannot be focused just in hospital, just in the community. It actually has to be focused at each point where distress or mental distress can present or be observed. And the approach in the Eastern Cape has been to then form a network which basically covers Department of Health duties, Department of Social Development duties, and Department of Education. The Department of Social Development is then targeted at offering crisis intervention within the community, so community-based interventions. The Department of Education is targeted at learner and teacher distress, while the Department of Health is targeted at mopping up anything that is not resolved through the Department of Social Development and Department of Education. But in addition, the Department of Health is tasked with mainly responding to healthcare worker mental distress and support. Next one. So this then is introducing the idea of psychological preparedness, which is a program that we then initiated in Nelson Mandela Academic, but also offered to staff in Mthatha Regional. And what this is an idea that I decided to come up with after noticing the degree of fear and anxiety that was observable in our staff in general. And I'm still talking about the very first week when we defined our case, our very first case in South Africa, which was back in March. And, I can share that the very next day, it was incredible the level of anxiety and panic that was already obvious in people within this mental health unit. This is not even considering people who would have been right in the thick of things, in casualty, in departments of family medicine, internal medicine, anesthetics. So it really made me think it could be useful to actually go and see what can actually be done pre-disaster to prepare people. And, it was possible to find quite a significant body of work that does say, yes, in times of disaster, one can actually prepare communities to face that disaster. And the conclusion was that prepared communities who are ready psychologically to face the disaster often do better than communities who are not prepared. So we then borrowed that thinking, which is based on natural disasters, and applied it to the pandemic, after deciding to view it as a type of disaster. And what it then means is that when you are busy with psychological preparedness training, you are focusing on getting the individual to be aware of psychological reactions, whether these are anticipated or are already occurring towards the disaster. You also want the individual to identify particular stress-related emotions and thoughts, which may have an effect on coping. And lastly, you also want to take the individual through what to do in order to deal with those overwhelming and stress-inducing negative emotions and thoughts. So this is basically the program that we started in Nelson Mandela. Next slide. We then decided to form a sort of support group made up of mental health, of the mental health team. We call the support group the Team Sisonke, which means we're all in this together. And what we then did is we started offering psychological preparedness training sessions to staff that were interested. And we would then take staff in groups of 10, sometimes a little bit more, And the aim was to actually put them through an hour and a half session, which is very interactive, which looks at fears, it looks at thoughts, it looks at behaviors around the outbreak. And the sessions also look at identifying what of these fears, thoughts, and behaviors are not enhancing coping, what of these fears, thoughts, and behaviors are actually enhancing coping. And then we come up with techniques of how they can then address all of those overwhelming reactions that do not enhance coping. We also encompass teaching relaxation techniques that could be used when one is feeling overwhelmed by fear, anxiety. And lastly, we also focus on how the individual staff members can work together as a team to make sure that the response to the COVID outbreak is a team response. Next slide. What we've then done is, we started the training in April, beginning of April, and so far we've trained 500 healthcare workers across the Eastern Cape. The main focus has been in Mthatha Regional and in mostly in Nelson Mandela Academic Hospital. We've also expanded the training to include staff in Doranginza Hospital, which is in BE, in Elizabeth Duncan Hospital, which is also in PE. And more recently, we've actually had requests from Department of Education and Department of Social Development to upskill their teams so that they are able to offer similar support within their departments, but also similar support for members of the community. Next slide. As I mentioned before, we have specific areas that we target that include identifying, distressing feelings, thoughts, or behaviors, and teaching people how to manage these. In addition, we reinforce the 5 principles that you will see, or 5 goals that you will see on the slide. These goals were chosen because the evidence that has come through relating to how to deal with disasters is very clear that whatever intervention you then offer to help a person deal with an impending disaster or a crisis, it's crucial to foster the following. And this is then something that we repeat throughout each and every session. The person has to at least have, a promotion of a sense of their safety is crucial. There's also, promotion of a sense of calm. So even when the person is panicking, it is crucial to then guide them to a point where they can start being aware of how much they're panicking, but also how to calm themselves down. Promotion of a sense of self-efficacy, meaning when the disaster hits, do I know what to do? Even if I'm scared about it, are there things that I have learned how to do in order to cope with a disaster? There's also an importance in terms of promoting a sense of connectedness. This sense of connectedness is, reflected in your connectedness to your team members, but also connectedness to people around you who may not necessarily be at work with you, like your friends, your family. So it is crucial to promote that sense of connectedness because it immediately lets a person know that we're in this together. And then the last one is always to emphasize a sense of hope, because with hope, at least whoever is on the floor, as much as the disaster may be affecting, everyday function, if there's a sense of hope, it means that person is not going to give up. Next slide. What we have then been able to do is we've been able to simplify the resources that you require when you run this kind of training. It requires a facilitator. It requires somebody who's reasonably well versed with mental health services. And the reason is because, as you facilitate and you take people through the different steps of this program, you've also got to be able to at least use your skills in mental health to judge levels of anxiety, to judge responses, and to also judge how well people have been able to receive the message. So the basics that we need is when we're doing face-to-face, it literally is a whiteboard markers, pen and paper, and we're actually able to do the whole session. We have since moved this to a virtual capacity, and the intervention that we are offering for Department of Education has been virtual. We also did a, I would call it, the very first test virtual session was with Department of Labor. And after we finish with Department of Education, we're going to move on to Department of Social Development. And I think what I'm going to do, don't worry about the next slide, is to just reiterate here that with our experience of running these sessions, I counted, I think, about 500 healthcare workers, and we started last week with Department of Education virtual sessions. We've gone through 30 of them with an aim of capacitating up to about 80 of them. And what we have then learned in terms of fears, in terms of thoughts and behaviors that people have indicated have not been that helpful for them, is there's recurring themes. And the themes have to do with worry, with fear, with anxiety, feeling low or depressed, feeling sad, feeling scared, having feelings of denial. But there's also been lots of feelings of anger against the Department of Health, about lack of support, frustration. And, what we then tend to do during the session is we tend to teach, the attendees how to try and focus all of those feelings, no matter how overwhelming they are, into an action plan, and how to then calm yourself down once you've devised an action plan. I'm going to stop there for now. Oh, one last thing I wanted to say, sorry. We have actually had a chance to also audit the program that we've been delivering. And unfortunately, the audit results only came through today. So I could not include them in this presentation, but what has been very encouraging is the significant difference in levels of fear, feelings of whether one is coping or not, feelings of whether one can support someone else who's struggling to cope or not with COVID. Those areas have shown a significant improvement if you look at the pre-training when we measure these aspects, and then the post-training when we measure these aspects again. So we are busy collating that, and we want to actually publish that data just to give an idea in terms of what these fears, thoughts, and behaviors that have not helped coping are, and how to address them in a way that is effective. Thank you very much.
Thank you. Thank you. And apologies, Zuki, for getting the agenda wrong. You're much... Thank you. Yogi, would you want to introduce Dr. Adeni?
Yeah, the next presenter is Dr. Vincent Adeni. He is a family physician at Sisulu University Hospital, and he's a senior lecturer in the Department of Family Medicine and Rural Health at Sisulu University. He is going to present on breaking bad news over the phone in the COVID era. Let me share his presentation.
Yeah. Thanks very much, Prof. Dr. Vincent Adeni here. I actually double as the chair for screening and testing committee for Sisulu University Hospital. We have the privilege of bringing together a team of brilliant and vibrant clinicians consisting of nurses, doctors, and pharmacists within our team. And one very important issue we quickly picked up was the fact that the department, through NHLS, usually will normally notify patients who screen negative for the SARS-CoV-2 responsible, the etiological agent for COVID-19. However, the responsibility to deliver the result of COVID-19 positive cases then fall on the doctor, and essentially we quickly then organize two doctors within our team who speak the local language, Kaswa, very fluently, to be able to deliver this message. Prof, can I have the first slide?
Oh, can't you see it? Okay. So, just go back. Can you see the slide?
Yes. Essentially, that's the topic. Can we move to the next slide? My talk will focus on three important aspects. Why do we consider the positive result bad news to patients? And also the what's the relevance for doctors who are essentially given the responsibility to deliver this news on the phone to patients, and why is it important for them to have appropriate skill in terms of managing patients on the phone, and also the steps to follow in delivering the news. Next slide, Prof. According to Buchman, he actually reiterated that bad news is any form of information that drastically or negatively changes the patient's view of his or her future, with regards to his health. And this is actually one of the breaking bad news is an essential skill, which most often are not associated with diseases such as cancer, HIV, and also loss of sudden death of a loved one. But can we then put SARS-CoV-2 or COVID-19 in this particular context? Next slide. What is the data showing? A lot of studies have been done with regards to assessing risk perception of people at community levels. I've just selected a few papers that have actually looked and assessed the risk perception at the population level, from South Africa to Ghana to Egypt, South Korea, and Canada. There is a common denominator in the responses of the participants in those studies. However, most of these participants actually agreed that COVID-19 is associated with very high morbidity, with significantly high risk for deaths, and again, with regards to risk of spread of the infection, everybody agreed that this is a highly, highly contagious disease. Next slide. And let's look at the realities based on evidence we have as of today. As at 5 a.m. this morning, when I looked at the worldometer for coronavirus pandemic, we could see that over 17 million people have been infected worldwide. And in South Africa, we've got, the numbers are rapidly approaching 500,000. And also, when you look at the number of deaths, over 600,000 people have died globally. And again, the data for the national mortality from COVID-19 is approaching 8,000 people. When we look at this figure and we then compare that with regards to the case fatality rate, which most papers have quoted to range between 0.5 to 4%, it does not really show the extent of this problem and the way people perceive this particular disease at the population level. And if you then compare the number of deaths, even though the case fatality rate appears very low, in comparison to Ebola virus or MERS, as well as SARS-CoV-1 of 2002, those viruses have higher mortality rate. But when you look at the total number of people that have died as of today, the number of the deaths to COVID-19 actually is far more than those viruses combined together, despite the very low case fatality rate. Next slide. And when you look at the risk of death from this particular disease, you will see looking at the hazard ratio of some of these comorbidities that are associated with increased risk of death from COVID-19, you will see poorly controlled diabetes ranking very high, as well as dose response effects from age. The older you are, the more the risk of death. And also the various other comorbidities that most of the population we serve, especially in Eastern Cape, equally have some of these comorbidities, which therefore increases their risk. And this again impact in terms of the way people perceive a positive result of SARS-CoV-2. Next slide. Again, we talked about the reproduction number, the time to doubling of this particular virus. It's again, we realized that initially we thought it's ranging between 2 to 4, but again, the data is rapidly showing that the rate of spread could be higher, and we equally know of the concept of super spreader, in which a single person can infect even larger number than that. And the implication of this in terms of the global pandemic has shown that, over 200 countries and territories are affected currently all over the world. Next slide. Next slide. And very important to emphasize that, again, in terms of the dynamics of spread of this virus, the patients begin to spread the virus 2 days before the onset of the first symptom. In addition, patients who are asymptomatic similarly have the capacity to spread the virus. These also impact in terms of the fear and the anxiety that a positive result invoke in those patients. And one of the key issues that we've realized and we have seen in our own setting in Eastern Cape and especially in East London area is that we are beginning to see clusters of disease within families. One person is positive, and when you screen the entire family, virtually everybody will have got the virus. And then those who are elderly and those with severe, with lots of comorbidities, you tend to see clustering of deaths as well within families, which therefore again invoke fear and anxiety when you deliver the result of COVID-19 to patients. And one of the key issues that we have picked up essentially, and again have been reported in the literature, is that even beyond the immediate threat to the life of that individual patient, they are more equally worried about their loved ones, those whom they have had contact with while waiting for these results. And these are some of the key issues that equally bring about sense of guilt and anxiety for patients, even including self-blame as part of the reactions that patients often display when you notify patients with the result of SARS-CoV-2. Next slide. Again, Prof Zingela has eloquently discussed some of the mental health issues that have been reported and have been, we are beginning to see in our practice population. Anxiety is a critical thing, whether it's among healthcare workers, including doctors themselves, as well as the patient at large. And one other key issue we are seeing very frequently is issue of social stigma and discrimination. A lot of patients who for some reason have continued to work while they were after being swabbed for SARS-CoV-2, immediately they are notified that they have positive result, and they then notify their immediate boss. You then begin to see immediate, this sense of discrimination, even starting from the boss, immediate line supervisor to this particular to patient. And these are part of the reasons why notifying patients with these results invokes a lot of anxiety. Next slide. For the doctors, it's or any clinician who would then be responsible for notifying patients with a positive result. A number of times, even doctors themselves they are burdened by the stress of this particular positive result. And sometimes doctors feel inadequately prepared, in terms of the communication skills of delivering this kind of results to patients. And there are a lot of complexities involved. There are a lot of questions on the concerns that patients raise that sometimes overwhelm the clinician or delivering this result. in terms of how are they going to manage or address those concerns. So sometimes this creates a form of anxiety for the doctor who is responsible for delivering this result. Next slide. Next slide. So essentially, in terms of the skills and the techniques that must be followed, it's important that the doctor should have empathetic disposition towards patients. Doctors who are going to be delivering this news must be ready to attend to the concerns of especially verbalized concern, if the delivery, if the breaking of the news is going to be on the phone. So there will be a number of variety of reactions that one should expect, and therefore you must be there to create time to be able to manage these concerns. Next slide. And implicitly, once the doctor have these skills in delivering this information to the patient, they are able to then have a more satisfied patient and a satisfied consultation with the patient. But again, let's look at the meter of the talk. How do you then go ahead and deliver this news to the patient after you have obtained the result? There are a couple of models that have been discussed in the literature. The SPIKES protocol by Bale et al. Yet in 2000 is quite very popular, which actually connotes setting up the agenda for delivering the news, perception, invitation, knowledge, emotions, and empathy, as well as strategy and summary. That is one protocol. And again, the ABCD model by Rabul and McPhee is actually another model. But essentially, the Bob March in the South African Family Practice Manual seems to have synthesized some of these models in a very concise manner or formats, which have adapted in terms of the way we deliver the news to patients. And essentially, there are about 5 steps, which I'm going to quickly talk through. The first is preparation for notification, setting up the scene, sharing the COVID-19 result, addressing the patient's emotional responses, sharing further management plans, as well as closing remarks. And definitely, next slide, Prof. So in breaking bad news on the phone, it's important as a clinician to be adequately prepared. You need to actually ask yourself what exactly are the information that are needed in you before you pick up the phone to discuss with the patient. One, it's important to know check that you've got the appropriate result for the patient. Name of the patient, very important. When was the swab taken from the patient? And it's important to equally review the onset of the first symptom in the patient, and also the date when you are the date when you are making giving the news to the patient, so that you can be able to estimate the de-isolation period, especially in patients with mild disease. And we would recall that in the early phase of the epidemic in South Africa, we were de-isolating after 14 days for mild disease. And of course, those with severe or critical condition then get to de-isolate 14 days after they've become stable, essentially off oxygen. And very important to then reassess the comorbidities of these patients, because these are the critical information that you need to have ready as you are talking to your patient on the phone. And also very important to be able to then pay attention to the conditions at home where the patient is currently de-isolating, where the patient is isolating, whether in the self-isolation or designated facilities, so that you have a broader understanding of these patients that you are going to be talking to. And it's also important for you as clinician to be able to set aside minimum of 10 minutes for you to be able to adequately address the concern and reaction the patient may display after hearing the news. And in our own experience as a Makiwani Hospital, a number of times a phone call is placed to a patient, and the patient is on the road driving, even though the patient is supposed to be in isolation, or patient is in the mall, or the patient is in a funeral. During the period the patient is supposed to be in self-isolation, So you then want to make sure that you have appropriate context to provide this result. And I think it's very important for us to equally know that confidentiality of information, especially when you are talking to the patient, is very, very important. However, we've noticed that in the last 2-3 weeks, there is a new development through the Department of Health where patients with positive results are equally notified of their positive result. And that has actually eased the burden on our doctors who are giving these news on the phone. Essentially, it has, the fact that the patient already had the result tends to then make them to accept the result better, unlike when we first started in the first 2-3 months. And in giving the news to the patient, it's important you as a clinician, you need to have set appropriate environment, make sure that you want to minimize interruptions, and you equally must check with the patient to know that the patient is in an appropriate place to be able to get the news. And it's important to really reassess the level of knowledge. Oftentimes, it's not the same doctor who took the swab who would deliver the result. And it's always very important to gauge the understanding of the patient or the misperceptions about the disease, as well as risk of transmission, which you need to inquire about, and then be able to address some of these issues, with the patient. And also, it's important for us to be able to pay attention to the current condition of the patient during the course of telephonic consultation with the patient, so that you'll be able to then provide immediate medical care for this patient. Next slide. So in giving the results to the patient, like I said, it's important to create time. You cannot be in a hurry when you are delivering the news for the patient, because the patient definitely may have a lot of concern. And some of the anxiety that the result usually invokes can actually be reasonably managed on the phone. And of course, if the patient's condition has changed from the last time the patient consulted, one can then be able to ask questions to quickly profile the current status of the patient and make a decision whether the patient needs to seek emergency care, for the patient, or perhaps arrange some form of follow-up care for the patient. So again, it's important to be able to discuss the severity and what are the form of management that may be available to the patient when you are delivering the news, and also to explore infection prevention measures that the patient may have been practicing since the last time the patient got swabbed, And when we deliver the news, you do not want to waste time in terms of getting to the point of the result itself. It's important to be able to give a warning shot to the patient, to let the patient know that the news is not what what she may have expected. But a number of patients, especially when there are family members who have got the disease, most of the time they already assume they've got the virus as well. And if their conditions still remain mild, with mild category, they might be able to undo the news better. So critically, it's important to go straight and let the patient know that you've got a positive result, and quickly check and clarify understanding that the patient have the same understanding with regards to the infection that the patient has got. And also allow the patient to be able to show his or her emotions. Then there are varieties of emotions that patients show. Some patients will just essentially they may actually shut down. There may be a period of silence, And then it's important to then elicit what the patient may be thinking of, the current concern about the diagnosis with the patient, so that you'll be able to provide some form of assistance on the phone for the patient. And also, it's at this point in time, it's also important to equally check and correct misperceptions, which you may need to do in small bits. Try to be with honesty for the patient, so that you do not want to leave the patient hanging with any form of misperception that could drive the patient to do or to seek help that may not necessarily be useful or evidence-based in this regard. Also, it's important to manage clinical condition of the patient, because again, depending on the turnaround time of the results, in our setting, the turnaround time initially was ranging up to 13 days, but the turnaround time has actually improved dramatically in the last 1 month, and we're seeing results within 2 to 3 days. And for patients on admission, we sometimes get a result within 24 hours. So it's important to be able to assist in whether they, for especially if patients' condition have deteriorated, that patient needs to immediately be advised to get to link up with emergency response to come and deliver, to come and seek emergency care. So in closing, it's important for the doctor to be able to reinforce risk of deterioration in the patient, especially the breathing of the patient. Most of the patients with difficulty will have labored breathing, and therefore if they notice that, they must immediately alert the emergency medical response to pick them up and bring them to hospital. And do not give false hope to patient, especially if patient is still within the first 5 to 10 days. Certain deterioration can still occur, and therefore we need to be careful about that. Then, what are the available resources to the patient? Very important to highlight this, and what patient must do if the condition changes. And for our doctors who are delivering these names, it's important that debriefing must be done. A number of times, the doctors are blamed for the prolonged turnaround time of some of the results. And I once had one of my doctors who felt thoroughly abused by the patient on the phone, because the result took about 13 days, So these are some of the experiences we have seen, and very important that you do not carry over your unpleasant consultation with the patient to the next patient. So these are some of the experiences we have learned, and have been able to train some of our doctors on how to bring back these news to patients on the phone. So I will stop there and take questions.
Well, thank you very much, Vincent and Zuki. Really appreciate it, and thank you, Yogi. I think we have run out of time. Yogi, thank you very much for arranging this wonderful panel. I think Vincent shared a very comprehensive approach to breaking bad news. I think Zuki's also shared an excellent proposal for managing staff and the issues with the Solidarity Program. I think those are really interesting. We've had lots of questions. I think hopefully you've been able to try and look at some of them and respond. Unfortunately, people are going to fall off, and it's kind of taken more than the 90 minutes we've allocated. I think the key question we have to ask is very quickly is how do we deal with this epidemic in the minds of our patients in places where the death rate is not as high as it could be, but it's clearly enough to set our anxieties up and show us to be quite fragile in terms of responding. And I think there's some excellent proposals on how to engage with this. This recording will be provided on the website, on the web link you've used to register. I must say, I'm really sorry that we haven't been able to engage in more of a discussion, but thank you all very much for attending. And once more, thank you to Prof Yogeswaran and this wonderful team from the Eastern Cape. I wish you all, listeners and everyone, to be safe, keep well, enjoy your weekend, and bye-bye.
Thank you.
Thank you all. Bye-bye.
Thank you, Prof. Bye-bye.